Dear chairs, ladies and gentlemen, my name is Janssen, and I'm most happy to give you this talk entitled How to Handle Flares in HBV Trials with Novel Agents. So what is the definition of a flare? Mostly what is used is more than 5 times the upper limit of normal. Some studies quote 10 times the upper limit of normal. But it's not only the height, the amplitude of the ALT or AST value, but it's also the rate which it goes up basically and your baseline level. So it is not always easy to define what a flare is if you do studies, because sometimes they go up very gradually, but very high, and sometimes they go up very quickly and move down again. On the right side, you see a grading, which is not really flares, but rather ALT elevations, I would say, moving from 1 to 4, from more than 1 times the upper limit of normal to eventually more than 10 times the upper limit of normal. If we're, I think, developing new drugs, we should allow flares to happen for sure, but to a limited extent, and it should be really well justified for the endpoints that we're looking for. As most of you will know, we have what we call good, bad, and even worse flares. The good flares is really an immune reactivity or host immune clearance, where there's death of hepatocytes, which is really accompanied by a decline in HBV DNA or HBS antigen, which is what we're looking for. Then there are bad flares. Those are ALT flares due to enhanced viral activity, where the virus goes up. For instance, due to resistance or lack of efficacy of a specific drug or stopping drugs. And the worst flare is really those that I would call DILI, so drug-induced liver disease. And that could be due to autoimmunity in the case of checkpoint inhibitors or to other mechanisms, really. Another way to differentiate the ALT flares is those initiated by direct antiviral agents and those initiated by immune modulatory agents. And if you look at the left side of the direct antiviral agents, there could be stimulation of the immune system even when you don't give immune modulatory agents, just decline the viral load and particularly the protein load very quickly. So that can cause a flare. There could be hepatitis reactivation and flare after stopping treatment, drug resistance, and DILI. And on the right side, you see that with immune modulatory properties, hepatitis flares could be due to immune clearance, directly an effect of the immune mediating treatment, a flare related to insufficient HBV DNA suppression, immune-related side effects like in PD-L1 blocking agents or checkpoint inhibitors, and DILI. So in the remainder of my talk, I will talk mainly on what these different types of agents, so agents that really inhibit replication, that give antigen reduction and immune stimulation, to what extent they will cause flares. I'll just give you some examples. It is important to know that as a baseline treatment, we're very often giving NUCs. NUCs very rarely cause flares. PEG interferon is increasingly used as a licensed treatment in novel treatment regimens. And there, as most of you will know, you can see definitely flares, particularly in E-positive patients roughly after 8 to 16 weeks of treatment on average. So here we're looking at an assembly study with a capsid assembly modulator, and typically they are rather safe drugs. Most of them at least are, with limited ALT increase. These are oral agents and are typically pretty well tolerated. So these are the early studies on Fibicovir. However, there are also camps which do cause flares. And actually 2 capsid assembly modulators have been taken out of development because of flares. So this is an example from an arbutus drug from a couple of years ago, and Gaston Pichot was kind enough to really give all these data, and they also presented that. So here, really, if you look what happens to these patients, you see in blue line that the HBV DNA is going down, and there's an ALT flare in most of these patients, and they were thought to be good flares, but then again, it's never good if it happens in healthy subjects, which happened here in this particular case, which really made this drug basically not a suitable drug, obviously, to further develop. So the flares were mainly seen in a subset of Asian patients, but also including of healthy controls. It's sometimes very difficult initially to see whether these flares are good flares or bad flares. And the question is this unique to this agent, or are there other capsid assembly modulators? And the answer is yes, because just a few months ago, another compound, in this case from Assembly, one of their newer camps, had a similar reaction where ALT flares were consistent and associated with drug-induced hepatotoxicity in this phase 2 trial. And also here the camp were taken off the shelf for further development. What about RNA interference? RNA interference thus far gives only limited ALT elevations and definitely limited ALT flares. There has been in this particular study, J&J compound, just a single case reported of abnormal liver test with an ALT peak of 136. There were no cases of simultaneous ALT 3 times the upper limit of normal levels and a total bilirubin, which increased. So at least from the liver perspective, they seem to be rather safe. However, if you drive down the protein load very quickly, you can encounter flares, as you can see here with this antisense oligonucleotide. So it's another way of RNA interference. And so what you see here on the top of this slide is 3 patients where S levels went down very, very rapidly, followed by a flare, which was pretty significant. And these were actually nuke-suppressed patients, but also in those who were nucleoside naive, there were patients who had an ALT flare really accompanied by an HBS antigen decline and HBS antigen loss, even in these 2 cases. So those you could really call good flares, and that's maybe a type of flare that we might need in the future. Here on the right upper side, you see the HBS antigen decline versus the ALT flare. And if you see the patients who had a maximum ALT, almost all of them with a pretty high ALT were the ones who had more than 2 log decline of HBS antigen. So it's obviously important to see whether there is a relationship between the flare and the HBS antigen loss or HBS antigen decline, and that might have happened here. So what about immune modifying agents here? An anti-PD-1 study, one of the few ones done thus far with nivolumab in a low dose, where there was 1 patient who became HBS antigen negative, and this is just 1 shot of nivolumab in combination with a nuke, and in 1 group in combination with a therapeutic vaccine. And here you see what happened to that particular patient with an ALT bumping up to roughly 300 values, and then finally moving down again in S with a very rapid drop, and becoming S antigen negative. What about if we combine all these agents? And this is a well-known study from Replicor, where they use their nucleic acid polymer, which is an HBS antigen destabilizer, or it reduces or inhibits really release of S antigen out of the hepatocyte. And this was given together with tenofovir and PAC interferon. And we, as most of you obviously know, we saw quite a significant drop of HBS antigen, but really accompanied by very significant flares. Pretty high flares were occurring in 95% of the patients. There was no alterations of liver function, so that's good. They were asymptomatic, and they were correlated with functional cure. But you have to keep in mind that you really cannot predict sometimes whether a flare would lead to liver failure, and a flare can be good, but if the patient becomes yellow and there's really synthetic liver dysfunction, a good flare can become bad very quickly. So it's good to tease out what the cause of the flare is, whether it's the NAP itself, whether it's its combination with PAC interferon. We really have to do more studies here. So lastly, I want to touch about withdrawals, so nucleoside analog withdrawals. A lot of companies are struggling how to deal with that, when to stop the nucleoside analog. We all have these stopping rules. but obviously you have to be careful here as well. And to reduce the risk, you have to take care of the fibrosis state, which should be low, the retreatment policy, the serological status, the absence of anti-HBe, which could potentially earlier cause a flare, rise of HBV DNA, and comorbidities. And if you look at treatment withdrawal, nucleoside analog treatment withdrawal, here you see that these are a few patients that lost HBS antigen after withdrawal, so had a very good reaction, but many of them didn't even develop a flare. So we don't think really that HBS antigen loss is necessarily associated with a flare. And if you look at the big flares with the nukes withdrawal, many of them don't become S antigen negative and don't even have an S antigen decline. Here you see like a bigger study. This is the Retract study that we did with among several sites around the globe. We collected the data of more than 1,500 patients, and after 4 years, we saw virological relapse in 83% of the patients, a clinical relapse, which is HBV more than 2,000 with an ALT then more 2 times the upper limit of 55%, and about 1/3 of the patient a flare. And here, in this particular case, there were 19 patients who developed hepatic decompensation, and some of them were associated with flares, some of them not always. Some of these patients developed HCC, and we're really teasing out now within this population what the role of flares was in these patients who developed hepatic decompensation and who died. So is there a way to evaluate flares in a better way? I think yes, there is, because it would be quite helpful if a flare occurs that either in peripheral blood or within the liver, we would get material and do proper immunological testing to see what's going on. And there are now more easy, I would say, ex vivo pooled tests that measure immune responses with these particular cytokines, relatively simple tests. And an even more interesting, I would say, scientifically sound method is fine needle aspiration with a small needle. You go into the liver, 25 gauge needle. You don't get any tissue, but you can get quite a lot of immune cells, more than 50,000. And with nowadays techniques like single cell RNA sequencing, etc., you can do a lot of very cool research with that. And that also can happen longitudinally, because the method is not really very invasive. It's like this, as invasive as a venipuncture. So to close, ladies and gentlemen, here's my summary, and the title of my talk is How to Handle Flares. So I'll try to give you some advice in this particular slide, and particularly how to de-risk flares and bad outcome of novel treatment in hepatitis B. I think we have to be very carefully on our tox studies, and that we're doing in animals. Do not cut too many corners, I would say. Some of the animal studies are not always indicative for what happens in the clinic in patients. I know that, but still, I think we have to do our due diligence there. I would say use nucleoside analog as a backbone of treatment that saves the patient from flares, at least due to resistance or an increase of HBV DNA. Otherwise, investigate particularly low-risk patients with limited fibrosis initially. And then I think we should carefully build up our combination treatments. And so don't go immediately to 3-4 compounds at the same time. And it's obviously the drug developers know that very well. We have platform studies where studies can be brought into a regimen or can be taken out. We should have the ability for flexible dose modification, which should be easy to do. You could use sentinel dosing where appropriate. So start with 2 patients, and then if they're doing well, then move to the next 2 or 3 patients. Always have a good data safety monitoring on board, and sometimes even a flare committee that can really tease out whether these flares are antiviral, virus associated, or because of drug-induced liver disease. And definitely, last but not least, be careful with stopping treatment. There have definitely been accidents in clinic, but also in clinical trials. So once you do that, monitor very closely and have liberal policies really on when to retreat. I thank you very much for your attention.